start her presentation and enlighten us with an interesting title, The Owl's Eye. The previous title was also very catchy, and this time we are having a title called Owl's Eye. Let's see what she has to say. Over to you, Dr. Nalini, ma'am.
Yeah, thank you so much, sir. And thank you for moderating this session so nicely. And a very welcome to all of you. So, the idea of putting this forward is like when we started our histopath, as sir has already said, there were many hiccups and there were very roadblocks when we started. So, the whatever we have gained over these years, the idea that we wanted to put this case forward is so each one of you are also aware now how to move forward in life, especially when you take up histopathology as a career. So with this, we move on to the second episode of the histopathology that gave sleepless night, and this time the episode is the owl's eye. So whenever any pathologist will hear about this owl's eye, the only thing that is going to come to his mind is and I hope each one of you will agree with me, and that is the Hodgkins cells, that is the Reed-Sternberg cell. So that is the agenda for discussion today, and we'll be discussing cases that have owl's eye appearance, the cells that mimic the Reed-Sternberg like cells, these cells which pose the diagnostic challenges, and then finally we'll come on to the gems that are to be remembered and that are to be followed when you start your practice and when you start practicing histopathology. So we'll move forward in this journey. So we'll move on to different cases as we had already seen in the last session also. So we'll be discussing them in two parts. In the part one, we'll be discussing half of the case, and in the part two, we'll be discussing the final conclusion to these cases and how they unfold themselves. So the first case is a 13-year-old female, and the lymph node was sent, cervical lymph node was sent. So that is the owl's one. Now, this is the lymph node from a 13-year-old female, a partially effaced or a completely effaced architecture. And as we could make out on this part also, that there are many of these large cells. So there are the number of these large cells are present, and along with that there is a polymorphous population. There is some histiocytes, some mononuclear cells with spindling, and there are other lymphocytes and plasma cells. So this is again a high power view of the same to show you that there are several multinucleated cells and there is a prominent big eosinophilic inclusion. So this is just reminiscent to that of an owl's eye, a big prominent nucleoli that we see there, and there are several lymphocytes and other mononuclear cells. So again another view of the same to show you these RS-like cells which have got a prominent nucleoli. Now this is again another multinucleate cells with this prominent big nucleoli, and there are scattered lymphocytes and other inflammatory cells.
Now, this is the lymph node from a
Okay. So when we see cells like this, the first thing that come to our mind, and especially when we are seeing a lymph node biopsy, especially from a younger population, then the thing that comes to our mind are these RS cell. So if they're RS cell, we would like to do a panel of immunomarkers to confirm whether or not they're RS cells. So the panel of marker that we use, and each one of us already have remembered that you should do a panel of CD45, CD20, 15 and 30. So these are the panel that you should do whenever you find any of these RSLs, and that is what we also did. So CD45, as you can make out, it is positive in the surrounding inflammatory cells, whereas the large cells that were seen there, they were CD45 negative. Then coming on to CD3 and CD20. So CD3 was positive in the surrounding inflammatory cells, and CD20 was negative in the large cells, as well as the background population was showing sparsity of CD20 positive cells. Now this was CD15, and if you could see carefully, CD15 was negative in nearly most of these cells. However, I have taken a picture from the area where occasional one or two cells were showing this paranuclear dot positivity, although the positivity was very dim and it was not absolutely membranous in most of the cells that were seen there. So most of the large cells were negative and only a few of the cells were showing this paranuclear dot positivity. So predominantly, if we have to say CD15 pattern, it is predominantly negative, and only less than 10% of the cells were showing you this positivity. Now CD30, this was CD30 immunostain, and it was showing you positivity in the membranous as well as in the perinuclear dot positivity pattern in the Golgi complex. So we'll stop here, and with this I would like to know your thoughts. So this is a 13-year-old female, and which was showing in a phased architecture with the presence of these large cells, and the large cells are showing us positivity with CD30 predominantly, and they were largely negative for CD45, CD20, CD3, and occasional scanty cells were positive for CD15. So what are your thoughts at this point of time? So you can put it in the chat box. So I hope I am audible to each one of you.
And which was showing in a phased architecture with the presence of these large cells. And the large cells are showing us positivity with CD30 predominantly, and they were largely negative for CD45, CD20, CD3, and occasional scanty cells were positive for CD15. So, what are your thoughts at this point of time?
Yes, audience, please pitch in with your thoughts.
Sir, I think there is a little lag with and the voice is also echoing. I think.
So, you can put it in the chat box.
Dr. BG, Fauzia, Michael, Sekhar, Dr. Carley.
So, I hope I am audible to each one of you. And it was showing in a phased architecture with the presence of these dancers and occasional.
So,
I think there will be a bit of a lag, ma'am. We'll wait.
yeah.
We'll wait.
Maybe we can. Shall we remove this Google Meet? I think because of that there is this echo is coming.
I think there will be a bit of a lag, ma'am. We'll wait. We'll wait.
Maybe we can remove this Google Meet. I think because of that there is this.
Okay, so as I could see that several of you have said that it could be Hodgkins. Was EMA was done? So EMA was done, it was negative. And then what we do is we'll wait here for the next of the answers, and we'll move on to case number 2. So just to, I think the echo was because of that Google Meet connection. So as of now we have we'll just stop here and we'll move on to the next case. I hope it's better now. If it's better, we can move on to the next case. Okay, so with this, your thoughts, most of you said that it could be Hodgkins. Some of you have said that we should do some other markers like MUM1 and EMA. So that we'll see later. We'll move on to the next case now with this. And the next case is in owl's eye appearance. The case number 2, that is owl 2. The 42-year-old male, and he had an inguinal lymph node. So a male, 42-year-old male, and the sections were taken from the inguinal lymph node. Now again, as you could see here, that the inguinal lymph node is showing you in a phased architecture. There is no nodularity and the entire architecture was replaced. It was diffusely, the cells were seen diffusely scattered throughout. So there is no nodularity or no other pattern that was visible on the lymph node. Now when we saw this, again, as you could make out that there are large number of these large cells which are being present there. And then in addition, you could see that the background is showing you these polymorphous population of cell. Now this is another view from the large cells. Some of them are showing you RS-like pattern which has got a prominent eosinophilic nuclei and binucleate cells, and apart from that there are other large mononuclear cells in addition to the lymphocytes that are being seen on the background. Now this again another view from the similar lymph node which is showing you the presence of these large cells and similar smaller cells. Now, as I said that whenever we see such kind of a picture, the first thing that will come to your mind is getting a basic panel done for Hodgkin's lymphoma. and that comprises of CD45, CD20, CD15 and CD30. So these are the basic things that you would like to do first, and this is what we will also do in this particular case. So let's see the CD45 marker. Now in this CD45, is you could make out the CD45, it is variably positive in some of the cells. So not all the cells are showing you CD45 positivity, but some of the cells are showing positivity with the CD45 marker as was seen here. Now the next markers that we should do for RS cell is CD3 and 20. The CD3, though it is highlighting the reactive lymphocytes surrounding the large cells, it was predominantly negative in the large cells that were being seen there. But when we come to CD20, the CD20 is predominantly highlighting all the large cells. So all the large cells are positive on CD20. So CD20 is a marker that is positive in all these large cells. Now coming on to CD30, that is again negative on the large cells. CD15 again highlighting the background granulocytes as you can see here, and some of these will be in darkly positive as opposed to the RS cells when sometimes they will show you dim positivity. But here all the large cells are negative on CD15. So now I would like to take your thoughts now over here. So we have an inguinal lymph node, and this inguinal lymph node, the patient is having a diffusely effaced architecture which is comprising of mainly large cells and polymorphous cell population. Now these large cells are positive for variably positive for CD45 but diffusely for CD20, and they are negative for 15 and 30. So when we have a large cell population which is mimicking that of RS cell, then when they are CD15 and CD30 positive, so what all things that should come to your mind? So somebody said NLPHL, that is Dr. Setu, Dr. Jayashri, they all said NLPHL. So nodular lymphocytic predominance Hodgkin's lymphoma is one. That is what we will also think here, that either it is a nodular lymphocytic predominance Hodgkin's lymphoma, or what else it could be, that we will see later, but at the moment we are going to stop here. So now these cells are not showing positivity either with 30 or with 15, but they are showing you positivity with CD20. So that is what we are seeing here, and with this we move on to the case number 3, and that is OWL3. A 55-year-old female, she had a history of dysphagia and odynophagia. So Dr. Setu also said that it could be T cell rich B cell lymphoma. Dr. Fauziya said it could be LP Hodgkins, or it could be an anaplastic variant of DLBCL. So yes, we will take all these things into consideration when we'll move on to the part 2 of these cases. So with this, we'll move on to the case 3, and that is the OWL3, a 55-year-old female, history of dysphagia and odynophagia. So for which she underwent a upper GI endoscopy, and on an upper GI endoscopy, her stomach showed nodularity, and there are also presence of erythema and patchy erosion. So there is nodularity and ulceration in the stomach. The RUT was positive, esophageal candidiasis, and there were gastric nodular lesions which they thought could be dysplastic, and then the biopsies were taken. So these are the different bits from the gastric biopsy. Now, as you could make out from this picture also, that all these different bits are showing you different morphology. So there were bits which were showing you this pattern, and there were bits which were showing predominant expansion of the lamina propria by a monomorphic infiltrate. So there were two kinds of bits that are being seen here. Now the sections from this bit, as you can make out, some of these glands are showing apoptotic debris, and there is also some enlargement of the cells here, and this bit is showing you a diffuse infiltrate with presence of several apoptotic bodies. Now this is a high power view from the second bit, and that is showing you that there is a diffuse infiltrate of large cells within the lamina propria, which is seen expanding the lamina propria, and at places the glands are disrupted, and there is also presence of apoptotic debris and high mitosis. Now this again another view of the same. Now this is a picture from the other bit that is showing you the presence of these outside like appearance, the cells which are enlarged, and they are showing you prominent big eosinophilic structures. So now when we see a monomorphic population which is predominantly large cell type, then again we are going to move forward with the B and T cell marker to see whether this population is a B or T cell type. So that is what we did. We did a CD20, and all the cells were diffusely positive for CD20. Now, they were also positive for CD45, 20, BCL6 and MUM1. They were negative for T cell marker, that is CD3, BCL2, CD5, 30, 10, EBV and CD15. So these markers were negative. CD15 and CD30 was negative, and the cells, the monomorphic cells, they were positive for 20 and BCL6. Now, this is again another picture that is showing you that CD10 is negative and MUM1 was positive in most of the large cells. Now, the area where we had these large inclusions, which we are really not aware what it is, and we were little wondering because it is also accompanied by a polymorphous cell population over here. So you could also see eosinophils, some polymorphs and lymphocyte accompanying these cells, which are showing you these large structures within the nuclei. Now, when a CD10 was done on these cells, CD10 was showing you positivity around these cells. So CD10, though it was negative in all the monomorphic large cells that were being visible there, it was showing you positivity around the large cells. So there is a divide. The monomorphic cells were showing you negativity for CD10, whereas these large cells where there was these prominent eosinophilic inclusions, they were showing you CD10 positivity. So now here I would like to stop here and I would like to take your thoughts. So we had a 55-year-old female. She presented with odynophagia, and that is all the history that we had at that point of time. And the history that was given to us was this only, that she had dysphagia and esophageal, the stomach was showing nodularity, and from the nodularity they had taken these biopsies to rule out whether it is malignant or not. So we had we had a picture, we had some bits which were showing you diffuse positivity with these monomorphic looking cells, and these monomorphic cells were diffusely positive for CD20 and BCL6. So we are definitely thinking of, Dr. Pavitra said DLBCL. Yes, we are thinking of DLBCL, but we are worried about those large inclusions that were being seen on those cells and large structures. They were showing positivity for CD10 and they were surrounded by those polymorphous population as we had seen. So most of you, Dr. Rekha, Dr. Mamta and Dr. Jayashri said yes, it could be CMV. So we also thought that could be CMV, but we are really weird to think of CMV here because the patient had a gastric nodule, and I don't know how many of you have really seen DLBCL with a CMV. So that was little worrisome for us, and we'll move forward with these thoughts in mind that it could be CMV, and then we'll discuss it further. So we'll stop here for the outside 3, and that is Dr. Chunni said that it could be CMV with DLBCL. Dr. Poonam said it could be CMV with DLBCL. So most of you agree with that, but we'll stop at the moment here and we'll move on to the owl 4. Now this was the most worrisome owl that we had, and this I will show you how. So this is the owl 4, a 42-year-old male with an inguinal lymph node biopsy. So a young, relatively middlehood adult male, and he had a biopsy from an inguinal lymph node. Now, this is the sections that we had from the inguinal lymph node, and what we could see here is the lymph node architecture is effaced. Yes, it is effaced. You could not see the cortex and hilar distinction. The architecture is defaced. Again, there are these presence of large number of large cells which are present everywhere. But in addition, we could see some sclerosis and some hyalinization that are creeping in through these surrounding these structures. So there is a prominent vascular proliferation that was visible over here, as you could make out. And then in between we have these large cells which are surrounded by a polymorphous population. So there are a number of these large cells surrounded by a polymorphous infiltrate, and in between we had these areas where there is a prominence of vascular pattern. So we'll focus our attention to the large cells that were being seen there, and these are the large cells that were present surrounded by a dense infiltrate of eosinophils and polymorphs and also lymphocytes. So definitely this is a polymorphous population that was being seen here, and these are the structures which are surrounding the different the polymorphous population that was being present there. So there were a number of these RS looking cells also that was present among these polymorphous infiltrate. So many of these are RS cell like, and they have got a prominent nucleoli. So these have got a prominent eosinophilic big nucleoli, and some of these are binucleated, some of them are mononuclear like, and then in addition these are being surrounded by a polymorphous cell population of eosinophils, lymphocytes and histiocytes. So again another picture showing you the presence of these large cells with the surrounding polymorphous cell population. And then there were these large vessels which we really don't know what it is, but they were also present over there. So as I said, when we see these large cell structures, so we move forward with the initial panel, that is CD45. It was coming negative in these large cells, as you could see here, and most of the background cells were positive for CD45. Now CD20, when we did, it was also negative in most of these large cells, and some of the background cells are showing positivity with CD20. CD15 and CD30 were very strongly and diffusely membranous positivity, along with some of them showing paranuclear dot positivity also. So most of the cells were positive for CD15 and CD30. Now EBV was also positive in these large cells. PAX5 was done to definitely highlight the nature of these cells, and many of these cells were showing you dim positivity with PAX5, indicating that these are of B cell lineage. Now Ki67 was also showing preferential expression within the large cells. So these are what you are seeing here, and they are showing you preferential expression within the large cells. So now we would stop here for your thoughts. So again, now we had an inguinal lymph node from a 42-year-old male, which is showing you effacement of architecture, which is showing you a polymorphous cell population with large number of these large cells. And then these large cells are showing an absolutely positivity for a dominant Hodgkins-like pattern. So they are showing positivity with CD15, CD30. There is negativity with CD20, and there is negativity for CD45. The cells were EBV positive. They were also positive for, as I said, Ki67, and PAX5 was weakly positive. So some of you said, Dr. Pavitra said it could be nodular sclerosis Hodgkins. Dr. Jayashree, Hodgkin's disease, nodular sclerosis. Dr. Rekha also nodular sclerosis, and Dr. Mamta Hodgkins. So most of you will believe that this is Hodgkin's disease, and that is what we also thought at that point of time, that yes, this is Hodgkin's, because the positivity is absolutely going in favor of a Hodgkin's disease. So Dr. Fauziya and Dr. Jasleen also said that it could be Hodgkin's. So let's wait for a moment here, and we'll think. So we have got nodular sclerosis Hodgkin's disease. So we'll come to each one of these one by one. So this is what I feel, that the residents, when they see large cells in the Hodgkin's disease, whenever they see large cells in the lymph node. So what the residents will feel when we also started as initially seeing these large cells in the lymph node. So the first thing, that we are very happy that we have found Hodgkin's disease, and then we should see a positivity with CD15 and CD30 to definitely say that this is Hodgkin's or it is not. So that is what the initial reaction will be, and most of you will jump to the conclusion that yes, 15 and 30 will be positive, and many of you are going to send it forward for IHC. So, but actually when you put your IHCs, there are many variations and there are many things more that you see, and that is what we are here to discuss this thing further. And we are going to hit the owl's eye in each one of these cases one by one. So let's move forward and move on to owl number 1. So this was owl number 1, a 13-year-old female, cervical lymph node, and we had seen positivity with 30 only. So the only marker that was coming positivity in the positive in owls 1, that was CD30, and we are seeing weak to patchy staining for CD15, that was seen only in 5 to 10% of the cases, and that too was really hard to see when we had to specially look for it in some of the cells. Then we could make out that yes, there is some perinuclear dot positivity. So only CD30 positive cells. Will this tell you that this is a B lineage or this is a T lineage? So when you have only CD30 positive cells, so will this tell you that this is a B lineage or this is a T lineage? So yes, so when you this, I would say that when we do IHCs, many of you will move to the right, to the left, and really some of you will think that what it is happening. So what next you are going to do when you have only CD30 positive large cells, when they are not showing positivity with any other marker? So what next thing that you would like to do? So the cells that were looking like RS cells, they are only showing positivity with CD30. So what next you will do to confirm the lineage of the cells? What next you will do, whether you will do a CD79, CD19, or you would like to do a PAX5. So what next you would do to confirm what is the lineage of the cells. So whether it is a B cell type or it is a T cell type, since the paranuclear dot positivity is relatively classical for a Hodgkin's disease, we would like to first rule out a B lineage. So out of these three, which of the markers would you like to do first? 79, 19 or PAX5? So Dr. Situ said PAX5. Yes, PAX5 is a very good marker, and that is an important marker to tell you that this is a B lineage. When we do CD79A, CD79 comes positive in the later differentiation part of the B cells. And though it starts from the early on, but more so positive in the later differentiation part. And for this, we would first like to do a PAX5 to see whether or not they are of B lineage or not. So that is what we also did, and we did a PAX5. Now when we did a PAX5, the PAX5 is coming dim positivity in these large cells. So if you see the background, some of the background B cells, if they are present here, so this is a B cell, it is showing you a strong positivity with PAX5, and most of the large cells are showing dim positivity with PAX5. So this kind of a positivity pattern is known for Hodgkin's cells, and by doing a PAX5, you can confirm that this is actually a B cell lineage tumor that we are dealing with, and the B cell lineage is CD30 positive together with CD15 variable positivity. It is actually a, now what we are going to think further, that is this a Hodgkin's or this is not a Hodgkin's? Is this a Hodgkin's or this is not a Hodgkin's? So we have a CD30 positivity, we have PAX5 positivity, CD20, 3 are negative. So what we are thinking now, is this a Hodgkin's or this is not a Hodgkin's? Yes. So with the PAX5 positivity, we can be really sure that this is a Hodgkin's lymphoma, and that is why some of you should include, like we also include PAX5 as an initial panel when we look at the Hodgkin's lymphoma. So the basic panel that we had for CD20, because most of the time CD20 will not help you much to categorize these cells as B cells. So doing a PAX5 is relatively good when you are looking for a Hodgkin's lymphoma, and that will tell you that yes, this is a B lineage marker, and together with CD30 positivity, it is a Hodgkin's lymphoma that we are dealing with. So there are different groups of Hodgkin's lymphoma that show variable positivity for CD15 and CD30, and the categorization of Hodgkin's lymphoma into the classical and the nodular lymphocytic predominance is actually based on the immunomarkers that we see. So if you have 1530 positive RS cells, so whatever we are seeing in Hodgkin's lymphoma is based on the immunohistochemical pattern that we see on the RS cells. So if you have 15 and 30 positivity on the RS cells, so it is not both, it is either you have 15 or you have 30. So 15 or 30 positivity both on the RS cells together with a B lineage marker will tell you that this Hodgkin's is a classical Hodgkin's. Whereas if you do if the cells are CD15 and 30 negative, but they are coming strongly positive for CD20, then we will think that this is a nodular sclerosis, nodular lymphocytic predominance, Hodgkin's lymphoma, and then together with the pattern that is being seen on the biopsy. So the OWLS one was a CD30 positive Hodgkin's lymphoma, where CD15 was only faintly and weakly positive. Now moving on to the OWLS 2, and that is a 42-year-old male, and he is presenting with inguinal lymph node. The large cells were diffusely CD20 positive, and they were variably positive for CD45. They were negative for CD3, 15 and 30. So now, as I said, when we are classifying Hodgkin's lymphoma, we are classifying based on the immunohistochemical pattern that we see on the RS cell. Now in this, the RS cells are negative for 15 and 30. So what next we should think of? So I think some of you have already answered. What next we should think of when we are seeing negativity for CD15 and 30 and we are seeing positivity for CD20? And that too a very strong and diffuse positivity. So if you have a diffuse strong CD20 positivity on the RS cell, so what next you should think of? What all differentials should come to your mind? So I think we have already discussed. Some of you have already said that this is a nodular lymphocytic predominance Hodgkin's lymphoma. So, so what do you want to do something to confirm the lineage? So that's the first question. You have CD20 positivity, so will you do certain markers to confirm the lineage? Here, do you require a PAX5 to confirm the lineage of the cells? No, you will not require, but you can do if you want to, because CD20 is already coming strongly positive. Now, can Hodgkin's lymphoma be CD15 and 30 negative? Yes. So, Hodgkin's lymphoma can be CD15 and 30 negative. We do not have much experience with this BOP4 and OCT2 because they are not coming that beautifully positive at our center. I don't know how about your places. But these, though they are mentioned in the literature, but they're not very helpful when we put them into practice. So, are you interested to know about the background population before you say that this is a nodular lymphocytic predominance Hodgkin's lymphoma? So before you say that this is actually a CD15-30 negativity and this is a CD20 positive nodular lymphocytic predominance Hodgkin's, will you be interested to see the background population, and is that of any help? So will you be able to see the background population? So let's go back and yes, we did a PAX5 and PAX5 was showing dim positivity in these case. BCL6 was also positive in the large cells that were being seen there. So now the question arises, is this a Hodgkin's lymphoma actually, or is this a variant of non-Hodgkin's lymphoma, that is T cell rich B cell lymphoma? So these are the two things when you have these strong CD20 positive large cells which are mixed with a polymorphous cell population. So how are you going to differentiate these two entities? So when you are going to differentiate these entities is by answering the last question, that yes, I am interested to know about the background population. We could also do an EMA if you are thinking of an anaplastic large cell lymphoma, but for this case, because they are so strong CD20 positivity, so EMA was actually not done, and then we moved forward with the next markers, and that is your CD3 and CD20, and then we looked at the background cell population. So the background cell population is showing you a predominance of CD3 positivity, and most of the cells are positive for CD3. So that is what we are seeing here, and if you look carefully here at CD20, the background cell population is largely devoid of CD20. So there are actually no B cells in the backgrounds, and all the cells that are being seen in the background is a T cell rich background. So we will now think of a T cell rich T cell rich B cell lymphoma. So in this particular scenario, some of these literature have also mentioned that you could do an immunoglobulin D staining, and on an immunoglobulin D staining, the cells, the large cells that are being seen there in a nodular lymphocytic predominance Hodgkin's lymphoma, they will be IgD positive. Whereas if you could see the control, the plasma cells are showing positivity with IgD, and the large cells, they are showing you negativity. So that again favors that it was actually a T cell rich large B cell lymphoma, and it is not a nodular lymphocytic predominance Hodgkin's lymphoma. The only thing that will help you to differentiate the two entities is to look at the background cell population, and once you look at the background cell population, that will tell you whether you are dealing with a CD3 predominant population or with a CD20 predominant population. So this was actually OWLS2 was a case of T cell rich B cell lymphoma. So with this, we move on to the next case, that is OWLS3. And for the OWLS3, we have stopped at the point where the diffuse cells were showing positivity with CD45, CD20, BCL6 and MUM1. So the large cells, they were all large cells, and they were showing you positivity with CD45, 20, BCL6 and MUM1. They were negative for T cell marker, that is CD3, BCL2 and CD10. And few of the cells in other bit are showing you positivity with CD10. So what further immunostain would you like to do here? You have some of the large cells which are showing positivity with CD10. They were negative for 15 and 20. So I think most of you have already said, and some of you like Dr. Poonam and others, they have also said that this could be CMV with DLBCL. So what next you would like to do here? What next? Is there any immunomarker that you would like to do here? Is there any immunomarker that you would like to do here to confirm your findings that you are seeing over there? And as I have already asked, how frequently do we see CMV with DLBCL? So this is my first case of seeing a CMV with DLBCL. I don't know about your center. So Dr. Poonam also said we would like to do a EBV. Yes, we would definitely like to do an EBV also. And I don't know how about at your places, because this is the first case where I was seeing a CMV with DLBCL. So is history important in this case? So I think before you do any immunomarkers, you should call back your clinician and ask for the history of this case. So for this case, again, we also thought we should call back the clinician. We asked them because the form only mentioned that there is a gastric nodule. So we discussed with the clinician, and the resident who was there, he told us that we specially asked if the patient is post transplant, and then he said, no madam, the patient is not post transplant. Then there was this dysphagia for which this biopsy was taken. So we were little skeptical that why so many CMV like inclusions are coming on the case of DLBCL. So later on, we discussed with the consultant, and actually the resident wasn't aware that the patient was post transplant. She was 14 years post transplant, and then this history became very important. And then we moved ahead with the CMV immunohistochemical markers, and they were diffusely positive in those large cell. So in a background of post transplant setting, this history is very, very important, because with this history itself, our findings are now confirmed that we are dealing with some viral inclusions. So now, as Dr. Mamta said, CD30 was also done for these cases, but it was negative. 15 was also done, that was negative. So they were all CMV inclusions that were being present there. And the history of a renal transplant 14 years back was relatively very important. She had several episodes of immunocompromised status and these viral history before also. So now there's one more question that raised our concerns was why CD10 was coming positive in these cells. So why the CD10 was coming positive in the cells that were showing you these inclusions? Any answers on that, why CD10 was coming positive? Because I think that is the only way that we learn, that we ask ourselves a question, why we are seeing this, why this is happening, and then subsequently we are going to learn many things as we evolve. So any relation between CMV and CD10? Yes, that is the question I had put forward to you. So is there any relation why CMV viral inclusions are showing you CD10 positivity? And the only thing that we could think of here is that because these inclusions are predominantly seen in the endothelial cells. So if you go back and look at the section where these inclusions were seen, most of these inclusions were present in the endothelial cells. So these are the vessels, and within the vessels we have these large cells, and these cells are showing you these CMV inclusions. So if you do a CD10, this is again an internal control that we see. CD10 comes positive in the endothelial cells also. So that is a catch here. And just by seeing the CD10 positivity should not take you away from a viral inclusion or should misguide you that yes, you are dealing with some lymphoproliferative disorder. So no, the CD10 positivity was coming in the endothelial cells in which the inclusions were present. So it was a case of CMV inclusion with the DLBCL. So that was the OWLS 3, and that was CMV with DLBCL, and definitely the history became very important here. It was an activated B cell type because we were seeing the negativity with germinal center markers. And what are the germinal center markers? And I think for all those who are doing the study for higher centers, now they ask you to subcategorize DLBCL based on the immunomarkers that you perform. They wanted to know whether it is a germinal center type or it is a activated B cell type. So if you have a activated B cell type, they will show you positivity with MUM1, rarely with BCL6. And if you have a germinal center type, then they will show you positivity with this the CD10. So CD10, MUM1 and BCL6 is the hence algorithm that has to be followed whenever you are doing any now reporting for diffuse large B cell lymphoma. So that is the OWLS 3 that we have hit here, and that is DLBCL with CM. Now, Dr. Aditi said it could be PTLD. Yes, it could be post-transplant lymphoproliferative disorder also, that we cannot exclude. And when they come as lymphoma, the picture is going to be absolutely the same. The only thing is you can go for an EBV testing also in these cases, that we have also done EBV marker, but that was negative. But not for all cases that are fully evolved lymphoma will show you EBV positivity as the early on cases. So it could be a post-transplant lymphoproliferative disorder, but for currently for this patient, it is a diffuse large B cell lymphoma with the CMV inclusion that needs to be treated. So that was the OWLS 3. Now we'll move on to the OWL 4, and this was the most dangerous OWL, I would say. And these are the cases that would definitely require some referral also from your end, because if you deal with these cases, they are the cases which requires a specialized opinion also. So the OWLS 4 we have discussed is a 42-year-old male inguinal lymph node, and they had these large cells which were showing you characteristic positivity for Hodgkin's lymphoma. So this kind of a positivity, if you get, especially for CD15 and CD30 and EBV, then you are really lucky if you get such a strong positivity. So that is what we were getting, CD15, 30 and EBV positivity, and they were negative for 45, 20 and CD3. So now this actually the case was that of a cardiologist, a very leading cardiologist from New Delhi, and this was his known to. So they were really up to us that what is the diagnosis, and the next day only they wanted to know the answers. So once we did the markers, we thought we'll discuss it with them, and we just called back the clinician, and there we got the blow. So he told us that the patient, the history was not mentioned on the form, and he said that the patient was diagnosed as Kimura's disease a year back, and it was at some other center. And for the Kimura's disease, this was present at the inguinal lymph node. The previous biopsy was also done from there, and it was now showing you this kind of a picture. Now at that point of also, we thought we'll give him a call, because there were these large vessels which were causing a concern and which were really not fitting into a Hodgkin's picture. Now, some of you have said that this could be nodular predominance Hodgkin's lymphoma. So when you have nodular lymphocytic predominance or nodular sclerosis type Hodgkin's lymphoma, in those cases, again, the large cells should have been CD20 positive. But here they are showing diffuse characteristic positivity for 15 and 30. And then though we have these sclerosis, we are really, they are not encircling the nodules completely. Rather, we have a very vague kind of a morphology where we are seeing these large vessels, though at some point they are also looking like a Kimura's disease. So how do you differentiate Kimura's from Hodgkin's? The first thing is the presence of these large cells. They are showing positivity which should not have been there in a Kimura's disease. Eosinophils, yes, definitely they could have been present at the Kimura's disease also. So that history now became very weird, and we were also a little skeptical and thinking what these vessels are like. So we looked at some other areas, and there we could see dense sclerosis, the predominance of these vessels, which were really very strongly prominent in apart from the large cell that we were seeing there. So in addition, there are these polymorphous cell population, which is showing you eosinophils and these large cells. So now the question is this Kimura's? So that is what he asked us, that is that the disease that you are seeing in the lymph node, is this a Kimura's disease? Question number one, is this Hodgkin's lymphoma? Because you are seeing the large cells with 15 and 13 positivity. So is this Hodgkin's lymphoma? Then he also asked, has the Kimura's transformed into a Hodgkin's lymphoma over some period of time? Or is this a T-cell lymphoma, some varied form of T-cell lymphoma, which is showing you this kind of positivity? So these are the questions that we had to answer. We were looking for Kimura's, and Kimura's, absolutely, this is a differential for Hodgkin's disease, because you see many eosinophils in both, but the presence of the large cells, the RS-like cells, and the CD15 and 30 positivity is taking you away from the Kimura's disease. So definitely we thought this is not Kimura's, but it could be a varied form of T-cell lymphoma. So we did a panel of pan T cell markers, that is 2357, and there was no loss of any pan T cell markers. So all the markers were intact, and there were no loss of any pan T cell marker. There was no aberrant expression for CD10, which is seen in angioimmunoblastic, because we are seeing these large vessels. So we were thinking of whether it is an angioimmunoblastic large B cell lymphoma. And at this point of time, we raised our hands up and we said that we are going to send this for a second opinion also, because this is a difficult case where we would require a second opinion. So now when the blocks were sent, the tissue that we were seeing here, they were positive for SMA and they were negative for HMB45. So it was sent to the Center of Excellence at the lymph node, and then from there we got that the cells were positive for SMA and HMB45, and though the final diagnosis that they gave was a Hodgkin's lymphoma with an angiomyomatous hematoma. So this was a case that was really very weird, and angiomyomatous hematoma again is a very recent entity. It is not a T-cell lymphoma, because some of the angioimmunoblastic T-cell lymphomas can also show you false positivity with EBV 15 and 30 like we are seeing here. So that was one differential here, but in this case it was an angiomyomatous hematoma with a Hodgkin's lymphoma. That was the final case, and this is a relatively recently described entity that is being seen in the inguinal lymph node, very common in inguinal lymph nodes, and more cases are now being picked up when you look at these inguinal lymph nodes, because they show you a distorted architecture, and seeing them with the Hodgkin's lymphoma was very weird. So this was about 2 years back, And I will tell you the follow-up for this patient. So this patient, we were very rigidly following him up, because when he started on to chemotherapy, we wanted to know how is the response, how will he respond to the chemotherapy that was given for Hodgkins. And then Dr. Rahul, he is a very close friend of mine, he told me that now he is in complete regression. He has completed his chemotherapy and he is doing really well now. So it was actually a case of Hodgkin's lymphoma, and time is the best teller. Time will tell you that these are the cases that you thought of as first diagnosis. These are the cases that behaved, how the response to treatment is the final thing that we should look for. So that was the final OWLS 4, and that was Hodgkin's lymphoma with an angiomyomatous hematoma in the background. So I'll move on to the concluding remarks here, and the concluding points that I would like to say. So the OWLS one, that I think these are the gems to be remembered when we practice histopathology, so that we don't make these mistakes very often and we are really aware of. Though as residents we are being told that most of the Hodgkins are diffusely CD15 and 30 positive, it's either or. So it is not both that are present all the time, but you will see some speckled focal positivity for CD15 at some places. So that is either or. And if I ask you which marker is more specific, CD15 or CD30, so which marker is more specific for Hodgkin's? So if like suppose you are doing CD15 and 30 for most of your Hodgkin's lymphoma, so of these two, which is going to be more specific for Hodgkin's, which comes positive in most of the cases and which is difficult to do, so which is difficult to interpret also at times, because sometimes CD15 will show you background staining with numerous granulocytes. So CD30 usually comes positive in most Hodgkin's lymphoma. CD15 in Indian population, it is relatively less common, but it is seen in several cases of Hodgkin's lymphoma. So you should do a panel of 15 and 30 both together with a B lineage marker. If you are not getting 20 positivity weekly also, then get a PAX5, which is a very good marker. Now, if you are in doubt if it is really a Hodgkin cells or it is not a Hodgkin cell, if you are in doubt whether these are OWLS or these are not OWLS, look at the background population. So look at the staining pattern of the large cells, whether they are 20 positive or 15 or 15 or 30. And then you look at the large cell, whether it is B or T type. So if it is predominantly B type, you think of a nodular lymphocytic predominance Hodgkin's. If it is a T type, then you think of a T cell rich B cell lymphoma. Actually, they are seen within a spectrum. So when nodular lymphocytic predominance Hodgkin's lymphoma it progressed towards the line of T cell rich B cell lymphoma. So some people have said that it is actually a progressive disease and it progressed to an NHL kind of a pattern. So look at the background reactive population, that is the learning from OWL side 2, and the learning from OWL 3 is CD10 can be positive in CMV, because these are the endothelial cells that will show you the positivity with CMV. And then finally the OWL 4, that rare entities you need referrals. So for seeing the rare entities, it is important to send these to a specialized center to know where they should come positive. So with that we conclude here. Thank you so much. And I think these are certain cases where things will become